This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is treating dizziness and other balance-related issues with physical therapy. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes, and your questions will remain anonymous. Today's presenter is Kristen Krozik, Assistant Director of Outpatient Rehabilitation at Mather Hospital. Kristen earned her doctorate in physical therapy from Stony Brook University and has been an outpatient physical therapist for 13 years. She has a certification in vestibular rehabilitation from the American Institute of Balance and has been treating patients with vertigo, dizziness, and balance disorders for over a decade. She's also an adjunct professor for Stony Brook University's graduate physical therapy program. Welcome, Kristen, and you can go ahead and get us started.
Thank you very much. Hello, everybody. Today I'm going to speak to you about treatment of vertigo, dizziness, and other balance-related conditions with physical therapy. So I'm going to share my presentation with you, and I'm actually going to turn my camera off throughout the presentation so you can focus on my slides. In just a moment. Okay, so let's start with the systems that help us keep our balance. We have three primary sensory systems that work together and all have connections to our brain. We have our visual system, which is the input from our eyes to see where we are in space. We have our somatosensory system, which are the receptors in our muscles, joints, our ligaments that give us feedback from the environment to, again, let us know where we are in space. And we also have our vestibular system. And this system is located in our inner ear, and it contains organs that communicate with the brain to help us see stable or non-moving images and help to keep our balance with head movements. So these three systems work together while we perform simple tasks such as standing, walking, or more complex and dynamic activities such as gardening, putting groceries away, doing yoga, hitting a golf ball. So anything we do throughout our day, these three systems work together to help us do it safely. Today, I will be focusing on disorders of the vestibular system and how we can treat that in PT. So here are some interesting statistics regarding balance and dizziness. Balance disorders can occur at any age, but are the #1 health complaint of patients over the age of 70. And approximately 90 million Americans, or 42% of the current population, will complain of dizziness at least once in their lifetime. So a negative outcome of these balance disorders and dizziness is that it increases our risk of falls. Each year, millions of people 65 and older will fall. That's 1 out of 4 older people fall each year. Some estimates state that as many as half of all cases are due to vestibular disorders. Less than half tell their doctor, and less than 10% of patients with balance and vestibular disorders are ever evaluated or treated by a specialist. And this will make them not receive treatment and not get better. So according to the Vestibular Disorders Association, people with measured vestibular dysfunction, so a person that is diagnosed with a dysfunction of the vestibular system, who are also symptomatic or experiencing symptoms, have nearly a 12-fold increase in the odds of falling compared with people who have neither of these risks. And people with vestibular dysfunction who are asymptomatic, who have the dysfunction but are not experiencing symptoms, also had a significantly increased odds of falling. And research shows that falling once will double your chances of falling again. And the prevalence rises with age, and it's approximately 2 to 3 times higher in women, than in men. So what does this mean? When someone has repeated incidents of falls, they experience a fear of falling. Then there's a decline in activity, which leads to decreased strength and balance, making it easier to fall again and compounding the already existing fear of falling. So symptoms of anxiety and depression can occur, impacting their ability to go out with friends, visit family, play with their grandkids, food shop, clean, and do some higher level activities like hiking, gardening. So people start to become more sedentary and don't want to go out. And this is going to impact their decline in balance. Balance disorders can occur at any age, but as we age, the risk of having problems in our balance increases. So there are age-related decline of balance receptors, muscle strength, endurance, and inner ear function, which we'll get into a little more. And just so you know, there are many reasons a person can experience loss of balance or dizziness. I just want to mention some of these, and many of these conditions or reasons are ruled out before there's further examination of the inner ear. So some causes could be medication side effects, ear infection, a head or brain injury, or a old head or brain injury, musculoskeletal imbalances, lower extremity injuries, low blood pressure that can lead to dizziness when you stand up too quickly. And what we're going to focus on is the impaired inner ear dysfunction or a vestibular disorder. So I just want to take a closer look at the vestibular system, just in case somebody doesn't really know much about it or know where it's located. It's located deep in our ear called the inner ear. And it's a sensory system, and it's responsible for providing our brain with information about motion, head position, and spatial orientation. It's also involved with motor functions that allow us to keep our balance, stabilize our head and body during our movements. And it gives us the ability to focus on objects while we are moving our heads. So going throughout your day, when you're walking around, rising up from a chair, turning your head, for anything, any functional activity during your day, there's a lot of head movement. Our vestibular system is responsible for us to see everything stable and to let us know where we are in space. So when there's vestibular dysfunction, what are some of the symptoms a person may feel? Some of the symptoms include dizziness, vertigo, which is a spinning sensation, and I'll talk a little bit more about that, falling or feeling as if you're going to fall, staggering when you try to walk, lightheadedness, faintness, or floating sensation, blurred vision or difficulty focusing, or confusion or disorientation, which a lot of patients will describe this feeling as that they feel that they're in a fog. So I want to briefly talk about vertigo. It's a common term that people use to describe dizziness, but it's actually something more specific than that. So vertigo is actually a symptom rather than a condition. So when a person feels a symptom of vertigo, it's a sensation of whirling and loss of balance that can be caused by disease affecting the inner ear or the vestibular nerve. It's a sensation that you or the environment around you is moving or spinning. Dizziness, on the other hand, is an altered sense of spatial orientation. It's a distortion of where we are within a space. And it basically feels like your balance is off. You're not necessarily spinning. That would be vertigo. So symptoms of vertigo, the spinning sensation, can be minimal or severe, finding it difficult to keep your balance and do everyday tasks. It could be sudden onset or episodic for longer periods of time. This feeling can last for seconds to several minutes, and it can be days to even months that these episodes are occurring. And again, there's a distinction to dizziness. So one of the most common causes of vertigo is something called benign paroxysmal positional vertigo. And we call this diagnosis BPPV for short. So basically, I'll just explain what the diagnosis, each word means. So benign is not harmful in effect, not malignant. Paroxysmal is a sudden attack. Positional is a particular way in which someone is placed or your head is placed. And vertigo is that sensation of whirling and loss of balance. And nearly 40% of US adults experience vertigo at least once in their lifetime. And this occurs during specific head movements while standing up or bending over or turning in bed or even getting out of bed. And this onset can be very sudden and very scary. It accounts for 20 to 30% of diagnoses seen in specialized dizziness clinics. It's pretty high. So what is actually happening with BPPV? So these brief episodes of the feeling of spinning, you have otoconia, which are calcium carbonate crystals, and they are located in our inner ear, and they actually bend these hair cells in the direction of gravity. So it's a process that senses linear acceleration, so moving forward, walking forward, and actually standing up. So any kind of gravitational change, it helps us keep our balance. Sometimes these otoconia, they can dislodge from the hair cells and they break apart, they weaken, and they float in our semicircular canals. And when this happens, the otoconia are floating when we change our head position or our body position, and that's when that vertigo comes about. There's that sensation of whirling and spinning, and as these otoconia float, you're going to feel the spinning, and as they settle in the fluid in the canals, the spinning will stop. And that's why these episodes are brief. So once they stop, a person is no longer symptomatic. But once they turn their head in the position that the otoconia are going to float, they get that whirling sensation, that spinning sensation. So that's basically what is happening. So besides the vertigo, symptoms of BPPV can also include loss of balance, nausea or vomiting, and that feeling of dizziness or feeling off. So there is physical therapy treatment for BPPV. So I'm just going to briefly describe what is done by a trained physical therapist. So a therapist will perform a series of simple movements. So first we assess which canal we think that the otoconia are floating in. So we do our assessment, and once we determine which ear, because you have two inner ears, one on the right and one on the left. Once we determine that, we can determine which maneuver will help. So then we will perform either an Epley or canalith repositioning maneuver, an Appiani or liberatory maneuver to help dislodge the otoconia from the canals and empty them into another area called the utricle, which they will then dissolve. So in many cases, 1 to 3 sessions will work. Other people might need the procedure performed several times to relieve their dizziness. And that's really just determined by their subjective comments of how they feel, if they're getting dizzy anymore when they turn their head or get out of bed. But once they become asymptomatic, we are confident that the otoconia have been dislodged from the canal. So besides BPPV, there are other vestibular disorders and symptoms that patients are experiencing. And we just want to, as a therapist, let people know when they should seek medical help. So if you are experiencing vertigo or other dizziness symptoms, balance issues that are persistent or keep coming back, that's really when you should get an exam by your general practitioner or see a specialist. And when you see a doctor with any of these symptoms, what usually happens is there's maybe a referral for further testing. So whatever the doctor feels that is necessary, like a brain scan or any kind of imaging, a VNG, which is done by an ENT, it looks at the inner ear more specifically. Blood work could be done. And once your doctor can rule out anything and rule in that it's an inner ear disorder, a referral to a physical therapist for vestibular rehabilitation would occur. So what is vestibular rehabilitation? So it's a form of brain retraining. What it is a systematic progression of exercise protocols that encourage your brain to adapt to the abnormal messages sent from your inner ears. So what's happening is that there are faulty connections that are making us feel dizzy or off balance. And what we do is we implement a very specific exercise protocol depending on your symptoms that help to retrain the brain, or I want to say strengthen. It's just like a general term that we would use for a person to become asymptomatic. So we're actually increasing the connections, healthy connections to the brain, so a person will not feel dizzy anymore, or their balance will improve. So the goal is to reduce or extinguish the hallucination or exaggeration of motion or after motion, and it improves or restores coordination of head and eye movement and balance and equilibrium function. So here at Mather, we have a vestibular rehabilitation program, and I just want to go through basically what an evaluation would consist of and how a program would be implemented. So when we see a patient, usually their chief complaints are vertigo, dizziness, something called oscillopsia, which is when you don't see images very stable, or there's something called nystagmus of the eyes, which is sort of the beating or the bouncing of the pupil. And that's all because of the inner ear dysfunction. Unsteadiness, pulsion, which is when you're walking, you feel like you're being pulled in one direction, or you have a sense that you're falling, but you're really not. Visual vertigo, which is when people have difficulty looking at backgrounds with a lot of texture, a lot of visual stimulus, and they actually start experiencing vertigo symptoms. Or balance disorder, anyone that's coming in with falls. A lot of times patients will come in having already seen a physician, and they may be put on some kind of medication. And some of the medications, the common medications that we see are antivert or Dramamine. These basically it's a sedative, so it dulls your senses and maybe makes your symptoms a bit better. It's not correcting the issue, but it's making it more tolerable. Or something like Valium or Ativan are sometimes prescribed, and this will actually diminish the central nervous system. So it's going to diminish, again, the symptoms a person is going to experience, making them more functional. So what we do, we go through a thorough history. So our history, our questions asked really give us about 80% of what is going on with the patient, where we think this is coming from, what we think the issue is. We go through present and prior level of function. We review any past medical history, past surgical histories, medications, and any test results, any tests that were taken before coming to our clinic. We do strength and balance assessments. We do an ocular motor exam, which is, we look at the ability for the eyes to see images clearly. Like I stated earlier, there's a connection from your inner ear to your eyes, and we test that. We have something called the Biodex in our clinic that we do a balance assessment on, which I'll explain a little bit more about that. And we do the positional testing for that BPPV, and then we administer any maneuvers that need to resolve that issue. So after our, initial questions and going over everything, if it's appropriate, we may do something called a clinical test of sensory integration of balance. And this machine we have is very interesting because it actually quantifies how well each of your systems that I spoke about earlier, your somatosensory, visual, and vestibular systems, are working compared to norms. So norms, your age group, your gender, your height, how well you're supposed to be balanced in all different conditions. So we do things eyes opened, eyes closed. And with this information, it, like I said, it quantifies how well each of these systems are working and gives us a printout where we can see where your deficits are. And it actually helps us to develop an appropriate treatment plan. It's part of our development. So that's interesting. That's a kind of a new additive that we have to our clinic. Then specific treatment plans are developed from all of our evaluative findings. So if a person is experiencing BPPV, sometimes they're coming in with multiple issues. There could be a positional vertigo going on, but then they also have other impairments, maybe like a inner ear weakness on one side versus the other, which are going to give them symptoms, vestibular symptoms. So when someone has BPPV and other issues, we like to treat the BPPV first. So we will administer any maneuvers necessary. And then we will go on to implement our exercises approaches. And these approaches are used to decrease dizziness, increase your postural stability and your gaze stability. A lot of times balance training is incorporated. So we will incorporate a progressive treatment program, and we use our Biodex machine a lot of times to do balance training. There's a force plate that can become unstable, that we would want to become unstable to further progress somebody's balance training. So that works really well. We also do a strength and conditioning program if necessary. So sometimes when patients have these vestibular disorders, or they've fallen, or all the other things I've spoken about, they may become more sedentary and they want to not do as much because they're fearful of those symptoms. So they become weak, they become deconditioned, and we have to, work on that as well in our program. And then cervical treatment. Sometimes dizziness and other issues can come from the cervical spine. And again, we do assessments for that. We will look at that to see if that's the case. And if that is, we'll do maybe some specific exercises for the cervical spine and manual therapy techniques. And with vestibular rehabilitation, our goal is to alleviate symptoms fully. So that's the ultimate goal. Some people with a vestibular disorder may not be able to fully relieve their dizziness or balance issues and may need to find ways to cope with it. A vestibular rehab therapist can help develop an individualized treatment plan to help self-manage their symptoms. Or they could refer a patient to another specialist that may also help, be able to cope with their dizziness and their other issues. But the ultimate goal, if possible, is to alleviate all symptoms 100%. And that will help a person return to function. So that is what we want. We want people to be able to go through their day and not feel dizzy, not feel off balance, and do all the things that they love to do. So I put this list up, just a couple of questions that you can ask yourself or someone that you think is experiencing an issue. So do I feel unsteady? Do I feel as if the room is spinning around me, even for a very brief time? Do I feel as if I'm moving when I know I'm sitting or standing still? Do I lose my balance and fall? Do I feel as if I'm falling, but you're really not? Do I feel lightheaded or as if I might faint? Do I have blurred vision? Do I ever feel disoriented or losing my sense of time or location? So if you answer yes, or you know somebody that would answer yes to any of these questions, then you should definitely seek, help and see a doctor. And maybe your issue is something that can be treated in vestibular rehabilitation. So I wanted to let you know that we have our phone number up here to make an appointment. It's best to have a prescription from your general practitioner or even a specialist. And feel free to call with any questions whatsoever, and we will direct you to the right maybe doctor or referral that you may need. But we do have appointments for vestibular rehabilitation, so please feel free to call us. Thank you very much, and I will take any questions.
Great, thank you so much, Kristen. Like she said, there's a Q&A spot at the bottom of your screen. Go ahead and type what you have in there and she'll answer as much as she can.
Okay, so I have a question here. What is the recommended course of action for individuals who have episodes of vertigo? Could be a few years to no episodes over a 2-year period. So I would say that the recommended course of action would be, if you're asymptomatic with your vertigo, coming for an evaluation may not show anything. So we really want to assess people who are symptomatic, because that's going to be able to best tell us where your issue is. So I would say if you are someone who experiences episodes of this, when you do have symptoms, that is the best time to come in for an evaluation, because then we'll be able to tell where it's coming from and maybe correct that for you, so it doesn't happen, periodically. It could resolve the issue fully. I hope I answered that okay. Is there a connection between vestibular dizziness and tinnitus? So yes, the ringing in that tinnitus is the ringing in the inner ear, that ringing sensation or hearing that people get in their heads. There is, what I would say is that a specialist, an ENT or an ear, nose, and throat doctor, would have to evaluate that, and because it could be also from a different situation. So that doctor would be best to determine if it's related. And then from there, with rehab, we would address that further.
Kristen, I also have a question myself. What about Meniere's disease and vestibular rehabilitation? Is that also an option to be treated?
Yeah, so Meniere's disease, there isn't a huge success with rehab because of the nature of the disease. Sometimes what we would do is something called substitution exercises. So we're sort of using the other two systems, the visual and the somatosensory system, to compensate for the Meniere's disease, the inner ear deficit. So yes, we do treat it, but we will treat it with trying to enhance the other areas, so somebody can be more functional and less symptomatic with substituting for the inner ear, yes. Okay, so I have another question here. I saw an ENT yesterday. He ordered an MRI. I told him I was experiencing vertigo, but as you describe it, it was more like dizziness. Can I call your number, wait for results of the MRI, or how should I proceed? Okay, so you would want to get your results for your MRI since you've already had that ordered. But in the meantime, you can call our number. And if you have a prescription, you can make an appointment with us. Or you can even call with any questions and I could speak to you directly. And okay. Do I need a script to see you? Yes. So it's best to get a prescription. A lot of insurance companies require that. So if you see, like I said, your general practitioner or a specialist, some people can go straight to a specialist, like a neurologist or an ENT, depending what your symptoms are. Once you have the prescription, you can make an appointment. And then, have you treated anyone with vertigo that has lasted for years, and is nausea also common along with it? Yes. So nausea and even vomiting can be associated with vertigo. And yes, I've treated patients with vertigo that have had it for many, many years. They just haven't had the right treatment. And once they are in the right hands or have the right treatment, it could resolve. And like I said earlier, our goal is to fully resolve. Some reasons for vertigo may not be able to be fully resolved, but we work as best as we can to make it as diminished as possible. And then, should I see a specialist because of episodic vertigo? It lasts for seconds. You could start with your general practitioner and then go from there. You don't have to go straight to a specialist unless your doctor feels that you need to. They may even just send you for vestibular therapy. And then, would this be acceptable? Another question is, would this be acceptable therapy for post-cerebellum stroke? Yes, it absolutely would be acceptable. So again, as long as you have a prescription, we would evaluate you, and we really, with our evaluative findings, that's how we develop your program. So whatever symptoms you're experiencing, we would develop a program appropriate for you. Let's see. Okay, I have nausea almost every morning and an episode of vertigo on occasion. Are they related? Well, I'm not 100% sure if that would be related. If the nausea is at a different time than the vertigo, that would be, I would suggest that if this is a continuous feeling that you're getting, that you should, see your doctor and get more information, because the nausea could be from something else. If it is from the vertigo, then, maybe that could be treated in therapy. And then I have a question. This is a good question. What is the particular name or title for the script? That might be from the same person as earlier. It would just say vestibular rehabilitation or vestibular rehab. That's what the script should say. Okay, and then I have a question, where are you located? That's a very good question. We are located at Mather Hospital. We are across the street from the hospital. We're located in a building that's 125 Oakland Avenue, and we're on the 3rd floor. And then let's see.
Yeah, it looks like you got them all.
Yeah, I think I did get them all. I hope I did. If I didn't, and I missed your question, because there's a whole bunch here I'm scrolling through, please feel free to, like I said, call that number. You can ask for me, Kristen Krozik, and I could speak to you and give you more information if needed.
Great. Thank you so much, Kristen. So if anybody needs to, please feel free to take that number off of the screen. You guys will be redirected to a brief survey after this. If you could fill that out, that really helps us plan our future webinars and give Kristen feedback. And thank you again for joining us today, and everybody enjoy the rest of their afternoon. Thanks.
Thank you.